Hi my dear friends, today we will discuss the second part of our presentation about ocular tumors. I hope you will enjoy my presentation. Conjunctival tumors. Primary corneal tumors are very rare, so tumors of the cornea mainly are extensions from the conjunctival tumors. Any conjunctival cell type can potentially lead to one or more of the conjunctival tumors. The majority of conjunctival tumors are benign. Malignant tumors of the conjunctiva are relatively rare. Conjunctival epithelial tumor, including melanocytic tumors, are more common than conjunctival stromal tumors. Some scientific terms which are important to understand our topic. The first is dysplasia. Dysplasia is a mitosis occurring in a disordered fashion in a suprabasilar epithelial cells. It is full thickness of epithelial cell layer are dysplastic. It is known as carcinoma in situ. In this photo, we can notice that the cells are arranged in normal pattern, while here the cells show mitosis with disordered fashion, which is called dysplasia. If the full thickness of the epithelium involved by these dysplastic cells is called carcinoma in situ. And if these cells cause breaking of the basement membrane of the epithelial cells, they cause malignancy and then they will cause metastasis. The second scientific term is acanthotic. Acanthotic means thickened epithelium, like this photo. We can notice that the epithelium here is so thickened. The third term which is important to us is leukoblake, which is a keratin formed on mucosal surface in the form of white plaques, like this photo. Conjunctival tumor classification, it can include benign tumors, including nevus, papilloma, epibarbadermoid, and lipothyroid, while pre-malignant lesions include primary acquired melanosis and intraepithelial neoplasia, or what's called carcinoma in situ. Malignant conjunctival tumor including melanoma, squamous cell carcinoma, Kaposi sarcoma, and lymphoma. Classification of epidermal tumors of the conjunctiva, including non-melanocytic benign, including squamous papilloma, like this photo. Keratotic plaque, or what is called actinic keratosis, which is believed due to prolonged ultraviolet ray exposure and can be listed as a pre-malignant lesion, like this photo. Reactive hyperplasia or pseudo-ophthalmopatous hyperplasia, which is active hyperplastic conjunctival epithelium. Non-melanocytic pre-malignant and malignant lesions, like actinic keratosis, conjunctival intraepithelial neoplasia, or what's called CIN, like this photo. Now we can discuss every tumor of them in separate, like nevus, as here. It is present in the first 2 decades of life. It is sharply demarcated and slightly elevated lesion, most frequently just a limbal besides the limbus, and 30% of cases are non-pigmented. Papilloma, it is presented by a lesion which is a pedunculated or sessile. They are usually present in the childhood or early adulthood. It caused by infection with human papillomavirus, maybe multiple and bilateral. In the sessile lesion, mostly it is presented in the middle age and not caused by infection, and single and unilateral. This is the pedunculated form, while here is the sessile form. Epibarbadermoid. It is what's called limbal dermoid or dermolipoma. It is present in childhood, smooth, soft mass, just limbal, occasionally occurring cases of golden hair syndrome. Lipodermoid, it is present in the adulthood, soft, movable subconjunctival mass, most frequently present at the outer conus. Intraepithelial neoplasia, or what is called carcinoma in situ, they present in late adulthood, just a limbal fleshy avascular mass. It may become avascular and extend to the cornea. Malignant transformation is uncommon. The main treatment here is excision with mitomycin application. The excision should be with a safety margin. Squamous cell carcinoma, which is a progression of the carcinoma in situ. Primary acquired melanosis, it is some sort of ocular pigmentation. Primary acquired melanosis, it is some sort of conjunctival hyperpigmentation. It is presented in late adulthood, unilateral regular areas of flat brown pigmentation, may involve any part of the conjunctiva. Primary acquired melanosis without atypia is a benign lesion, while primary acquired melanosis with atypia is a very malignant lesion. Conjunctival melanoma, it can arise from primary acquired melanosis with atypia, which is the most common type, with sudden appearance of a nodule in primary acquired melanosis. From nevus, here it is a very rare and characterized by sudden increase in size of the pigmentation. And primary, it is a solitary nodule and usually just a limbal and may be anywhere. It can be here, this mass, we can judge whether it arises from the conjunctiva or from underlying ocular tissue like ciliary body, for example. Treatment of conjunctival melanoma, if the tumor is localized, we can remove it by excision and adjunctive cryotherapy. In cases of diffuse tumor, excision of the nodules and adjunctive cryotherapy or application of mitomycin C. In cases of orbital recurrence, treat by excision and radiotherapy or excineration. Squamous cell carcinoma, it arises from intraepithelial neoplasia de novo, present in late adulthood and frequently just limbal. Progression, it is a slowly growing tumor, may spread extensively and rarely metastasizes. Kaposi sarcoma, it affects patients with HIV. It is vascular, slowly growing tumor of low malignancy. The tumor very sensitive to radiotherapy and most frequently in the inferior fornix. Lymphoma, usually present in adulthood, benign or malignant. It is salmon colored and characterized by subconjunctival infiltrates. Intraocular tumors. Intraocular tumors can include uveal tumors, which arises from iris, ciliary body, and colloidal melanoma, retinal tumors, including Retuning Blastoma and metastatic tumors. Uveal tract tumor, including the iris, which can show nevi, which is a benign flat to slightly elevated lesions, or melanoma, which is a malignant tumor and represent 5 to 10% of uveal melanoma. The age of presentation from 50 to 60 years, elevated and more pigmented lesion, treatment mainly by local excision plus minus radiotherapy with good prognosis. This photo of iris nevus, like here, while here is uveal melanoma with extensive pigmented lesion involving a sector of the iris. Ciliary body melanoma. It is 10% of cases of uveal melanoma, only visualized when the pupil is widely dilated. Presentation depends on the size and the location. Can associate subluxation or localized lens or central vessels, erosions of the anterior chamber with posterior extension and causing retinal detachment. Ultrasound here is very essential. Treatment by enucleation, local resection, and radiotherapy. Prognosis is poor, as usually presentation is usually late. Ciliary body melanoma. In this photo, we can notice that there is a mass arising from the ciliary body and causing pushing of the lens and displacement of the lens. Colloidal melanoma. It is 85% of the uveal melanoma, most common during the 6 decades of life. Raised pigmented oval-shaped mass, occasionally amelanotic, commonly asymptomatic, found in routine fundus examination, may cause decreased visual acuity or defect in visual field, can cause exudative retinal detachment, secondary coma, cataract, and uveitis. Colloidal melanoma may be peripheral, like this photo, and be a subretinal lesion, or be at the macula, and here be below the macula and subretinal in nature. Diagnosis of colloidal melanoma: first by ocular ultrasound which can diagnose the mass with overlying retinal detachment. MRI of the orbit also shows the tumor and check if there is extraocular spread to the optic nerve. Fluorescein angiography show increased vascularity and leakage from the tumor with subretinal lesion. Differential diagnosis of choroidal melanoma. It includes retinal detachment, metastasis, neovascular, age-related macular degeneration, and large choroidal nevus. Medical evaluation of these patients include: we should exclude metastasis from any part of the body, like the lung and breast. Metastatic workup should be done in the form of chest X-ray, abdominal ultrasonography, MRI, and mammography. We also should evaluate if there is extension or metastasis from choroidal melanoma to different parts of the body, like the liver and the lung. Management of choroidal melanoma: we should consider visual acuity of the involved eye, size, location, extent, and apparent activity of the involved eye. State of the fellow eye is very important in our management, general health and age of the patient. Treatment of choroidal melanoma: it includes radioactive blake, which is a metal blake containing the radioactive material and suture to the site of the tumor, inoculation, cyclotron generated charged particle radiation, photocoagulation, transcerebral thermotherapy, localized resection of the tumor, and excineration of the totality of globe and orbital tissue, and palliation with chemotherapy. Another important intraocular tumor is the Retuning Blastoma. It is a tumor of primitive photoreceptor cells of the eye. This is the most common primary malignant intraocular tumor in the childhood. It occurs as 1 in every 20,000 live births. Retuning Blastoma. Average age of the presentation is 18 months. Majority diagnosed by 3 years of age. Early treatment can save vision and the life of the patient. Other primary tumors such as sarcoma may develop in about 10% of cases. There are two forms of disease, which is heritable form and non-heritable form. Retinoblastoma, main presentation by leukochorea or whitish pupil, while another presentation is a squint of the affected eye. Differential diagnosis. Differential diagnosis is causes of leukochorea in children, like first, like persistent hyperplastic primary vitreous, which is called PHPV. It caused by failure of embryological primary vitreous and hyaloid vasculature to regress, developing cataract with whitening of the pupil, like in this photo. The second differential diagnosis is Coats disease, which is a unilateral disease characterized by development of blood vessels behind the retina with retinal detachment, causing picture resembling retinoblastoma. Toxocara canis. It is an infectious disease of the eye associated with infected pupils. It is transmitted from dogs to human, causing retinal detachment, like this photo. And lastly, retinopathy of prematurity, which occurs in low persuaded infant who receive supplemental oxygen imbued immediately after birth, leading to retinal vascularization and retinal detachment, like this photo, which characteristic retinal detachment and retinal vascularization. Retinoblastoma. In big fundus picture, we can show pinkish white raised lesion with blood vessels on the surface. We can show also calcification, especially in ultrasound, or we can see retinal detachment. Microscopic pictures. Undifferentiated element and be a collections of small rounded cells. Differentiated forms include flexner, Weinsteiner rosettes, like this photo, or homarite rosettes, like this photo, or florets from photoreceptor differentiation, like this photo. Retinoblastoma. 1/3 of cases are bilateral and present earlier than unilateral tumors. The bilateral tumor is mostly heritable form. They are familial and autosomal dominant. Only 6% of patients have a positive family history. Patients with familial retinoblastoma have a 50% risk of transmitting the disease to their children. Sporadic cases usually uniocular but can be bilateral. Retuning can spread transclerally to the orbit via the optic nerve to the brain and via blood to bone marrow. Investigations are ultrasonography, like this photo showing the tumor with calcification. CT, we can see the tumor and the calcification, and lastly by MRI, which shows the tumor and extension to the optic nerve and to the brain. Treatment of retinal blastoma include enucleation or external beam radiotherapy, thermotherapy, cryotherapy like this photo, and chemotherapy. Very important in retinal blastoma, any child under 5 years of age who has recent leukocoria squint of loss of vision must be examined thoroughly to rule out retinoblastoma. Metastatic tumors. It is more common than primary malignancies. The commonest primary site in women is the breast and in men is the bronchus. Less common sites, kidney, testes, and GIT. They may present with decreased visual acuity in one or both eyes. Solitary or multiple creamy white placoid or oval lesions in the fundus picture. Treatment mainly by chemotherapy or radiotherapy. Metastatic tumors of the breast cancer. Here we can notice that there is lesion, which is metastasis. Thank you very much, and I hope you enjoy my presentation. Thank you.